So good evening all. I'm Jennifer, and it's my pleasure to welcome you all to today's medical webinar on the topic Baby Steps to Baby Care, a talk on general pediatrics. We're very happy and honored to invite the presenter for the evening, Dr. Neha Mohan Rao. Dr. Neha is a pediatric pulmonologist working as a consultant at Baptist Hospital, Bangalore and Allergy Central, Bangalore. Neha completed her MBBS from JSS Medical College, Mysore, followed by Diploma in Child Health from St. John's Medical College, Bangalore, and a DNB Pediatrics from Bangalore Baptist Hospital. She then did a 2-year fellowship in pediatric pulmonology from Pune and Birmingham, UK. Dr. Neha's other interest includes pediatric ethics and medical education, and outside of work, she loves to travel and explore new cities and countries. Very happy and honored to have you, Neha, today with us. And before I pass on the session to you, I would like to invite FFE's Managing Trustee, Dr. Sudha, to say a few words, please.
Thank you, Jennifer, and good evening, good afternoon, everyone. It's almost evening, but I want to take this opportunity to welcome all of you students to this medical webinar, and I'm particularly happy and delighted to welcome our doctor speaker, Dr. Neha Mohan Rao, and I'm really happy that you can join us today. This is the second in our series for this financial year, and we hope over time we can cover several specialties with doctors like you who are making time to speak to our students. You probably know about the Foundation for Excellence. These are students who are getting merit and means scholarships, attending over 250 medical colleges all over India. And we have students here in various years of study. And what we are trying to achieve through these sessions is to give them an opportunity to interact with specialists and have wider exposure to career options, what they can consider, what various fields offer them, so that they can make informed choices as they go forward. Thank you so very much for being with us, Dr. Neha, and over to you, Jennifer. Thank you. And students, I'm so glad you all are here. We expect a lot more of you to participate. And I think those numbers are, I can see the numbers go up. So I'm really happy that all of you can join.
Thank you, Sudha. Thank you very much for being here with us today. And before I pass on to Dr. Neha, I would just like to let the participants know that this is going to be a very interactive session. So request all scholars, participants to please keep posting your questions in the Q&A box, which will be taken over by the presenter, Dr. Neha, later in the session. Thank you, and over to you.
Thank you so much, Jennifer. Thank you, Madam Sudha. It's a pleasure to be here today. And thank you all for joining in on a Sunday afternoon. Jennifer has very kindly introduced me as a pediatric pulmonologist, but I sort of prefer to be referred to as a pediatrician for this talk, because the foundation of all pediatric subspecialties at the end of the day is general pediatrics, very close to my heart. So I'll start off. I have a few slides, and I've sort of put together some stuff that I thought would be relevant and important for today. Please feel free to put in comments and questions in the chat box, and we will try and get to it at the end of the session. And I'm not sure if you can interact in between by unmuting yourselves. That may lead to a little bit of chaos given the numbers that we have. So maybe just best to put everything into the chat box, and I'll have a little peek there. If it's okay, I will share screen now. I'm not sure if you can see my screen. Just a moment. There are a lot of things that are showing up.
Yes, we can see your screen.
Yeah.
PT that you're sharing. Yes, yes.
Is this okay?
Yes, Dr. Neha.
Yeah. Okay, great. So I've called this talk Baby Steps into Baby Care, because this is just a little briefing on what we do in general pediatrics. I'm based out of Bangalore, and this is my email address in case any of you want to get in touch with me for any further details or any discussions. I'm happy to connect with any of you. So, if I were to start, I'm just going to start with, what do you think when you think of the branch pediatrics? And here we have a little slightly grumpy looking pediatrician giving two little kids some shots or vaccines. So, I mean, if I were to ask the general public what they think of the term pediatrics, here are a few responses that I think that I would get. Some of the undergraduate students just think pediatrics is fun because you have kids with you all the time, and kids are usually happy and playing and little less cranky than adults. So yes, it is fun. A lot of people think it is stressful because you're dealing with unwell kids most of the times, and they may not particularly be in the best of moods. Some people think that you're dealing with cute little babies who are smiling all the time. Absolutely true. Some people think that these babies are crying all the time. A lot of us are worried that, oh my God, how do we remember drug doses for pediatrics? Because pediatric drug doses are very, very complicated. And a lot of us think that the profession is very gratifying because kids not only fall sick quite quickly, but they also recover from illness very, very quickly. And the moment they start feeling better, they're smiling and they're up and about and, you know, laughing and playing. And that's probably one of the best parts of pediatrics. So these are a few answers that I think most of us would get when we discuss pediatrics. And for today's talk, what I plan to do is maybe start with a general overview of what we do as pediatricians, what are the kind of patients that we see in our OPDs, then maybe touch upon a few things that are important to pediatrics, right from the pillars of pediatrics, which we would like to call growth and development, a little bit about nutrition, a little bit about immunization, go into a little bit about what we do when we do a history and examination for a child, go into a little bit about why I chose to do pediatrics, what kind of subspecialties are there in pediatrics, what are the possible opportunities in the future, and then we'll take up questions at the end of it if that's all right. So what do pediatricians do? We treat children when they are unwell, and all of us know this, but we also do a lot of other things. We help prevent disease in the long run. We advocate for children. I think this is really, really important because, as you know, all children have rights. These rights are declared by the United Nations. They have rights to a lot of things: right to education, right to participation, right to have a healthy childhood, right to a lot of things. And as pediatricians, because they have no voice for themselves, because they're too young to speak for themselves, we are their biggest advocates in addition to their families. So it's really important for us to remember that this is one of the biggest things that pediatricians do. We listen to families and parents, and I think we're the only subspecialty that spends as much time treating the family as they do treating the patient. And we also help build a good society for them to grow in, you know, a healthy society for them to grow in, both physically, psychologically, mentally. So here are a few child's rights that we sort of speak about, given by the United Nations. And it is our duty to ensure that every child has, or every child's right is protected. And that's one of the things that we do as pediatricians. That's one of the things we keep in our minds every day. So what would I call the pillars of pediatrics or general pediatrics? So these three things that you can see here: growth and development of the child, immunization and vaccine related practices, and good nutrition, in my mind, would constitute a well child. Now, when we say growth and development, I will go into a little bit of detail of what we actually do when we sort of monitor the growth of these children. What kind of development are we talking about? What happens to their developmental milestones in the first few years of life, and why we're so obsessed about watching out for it and making sure things are on track? What happens if they're not on track, and how we help children who are slightly delayed in their development. In terms of immunization practices, a little bit about what kind of vaccines there are and what are the changes that are there in the 2023 National Immunization Schedule. What does immunization generally do? It not only helps with protecting the child, but it also helps in building herd immunity over a long period of time. And nutrition, of course, which contributes to growth and development of the child. Nutrition, how important it is, what we're talking about for an infant, breastfeeding and its practices, and a little bit of an older child, maybe a toddler or a preschooler, what kind of food should they have on their plate. All of these contribute to a well child. Now, the most important and the most beautiful aspect, I think, of pediatrics is that, you know, it's a specialty that is governed by age. We have children of different age groups, right from the neonate. Sometimes we have even premature babies. I'm not sure if you know, but in our neonatal ICU, sometimes we take care of babies who are as premature as 23 weeks, 24 weeks, which means a normal pregnancy is about 40 weeks, that's 9 months. But babies who are born at 5 months and 6 months, so 23, 24 weeks, we watch them grow and we watch them become babies and then preschoolers and then school age children, adolescents, and then adults. So, we have a really wide spectrum of age groups that we treat. And of course, we have a few special populations. Now, I've only mentioned a few here. One is a sick child, a really acutely unwell child who comes into the emergency and then goes into the ICU. The second set is a child with special needs, and we need to do special things to take care of these differently abled children. Then a child with a chronic illness. A child with a chronic illness sort of poses its own challenges. Taking care of that child. Also, if that illness is actually going to cause that child a lot of pain, then what kind of pain management we can do, what kind of palliative medicine there is for these children, all of that, that's a whole ball game by itself. And I've only put another group here into the special populations group, and that's the adolescent. I think it's important that we address the adolescent as a special population because the way that we interact with adolescents, the way that we treat adolescents should be different from what we do for children and different from what we do for adults. Now, there are a few other sets of people or a few other groups of people that I'd like to include into this special population group. Those are children who have, let's say, who have suffered from some sort of a natural calamity, like they've come out of a war setting, they've come out of a remote area, floods, famine, a child, let's say, who's lost a parent and has sort of undergone a lot of trauma or stress in their life, a child raised by a single parent, all of these children, a child who is a victim of any sort of abuse, all of these children come under a special population group as well, and pediatricians deal with that as well as on a daily basis. So what do we see in a pediatric OPD? And look at this little baby who's doing that cute dance there. So mostly we see well children who come in for vaccination. When this well child comes in for vaccination, it's not simple for us because it's not like we see the child, we play with the child, we write the vaccine, and then the vaccine is given by the nurse or we administer the vaccine ourselves. We also look into growth, development, nutrition, immunization at every visit. It's very important for us to do that. These vaccination checks seem to act like checkpoints, while the child is growing, for us to sort of take stock of what has happened over the last couple of weeks or last couple of months. And what I'm putting here is basically what you'd see in a pediatric outpatient department, not the emergency, and not in a hospital setting where, you probably have some pediatric subspecialists already there, but this is the routine stuff. So if you see here in the beginning of the circle, you have acute illnesses, like you have a child who comes in with a fever, cough, cold, or a respiratory tract infection, a urinary infection, dengue, whatever kind of other related fevers we have. We also have children who come in with chronic problems. Sometimes we identify them either in our well visits or they come to us with these issues. They're not gaining weight or they have a chronic cough. These are some of the examples I've just put up. Then we have newborns who come in with malformations or deformities right from birth. I've just put down syndrome. That may not necessarily always be the case. There may be other sort of problems that you'd pick up at birth that you'd sort of probably have to treat and follow up. Then you have children who are not following their normal developmental curve. They're slow to walk, slow to talk, slow to acquire skills. Parents are worried, and you sort of have to evaluate them. And then we have another set of children who come in with a lot of behavior problems. Most of these are benign and tend to be age-related, but sometimes you pick up children with hyperactivity, sometimes you pick up children with eating disorders, and we help parents and families navigate through these problems. So I'll take about 5 minutes and just speak to you about why pediatric history taking and examination is different from adult medicine. I'm assuming that you're familiar with adult medicine history and physical examination to a large extent. For those of you who've started clinics, I'm sure you're familiar with it. For those of you who've not started clinics, right from the beginning, you'll sort of know the differences between pediatrics and adults. But for a good pediatric history, I think these are the things that we need to keep in mind. You observe the child, and it's so important to see what the child is doing while the child is waiting outside your outpatient. Is he happy? Is he cranky? It'll give you an idea of how severe the illness is. And a lot of children come into your OPD and they just cry as soon as they start looking at you, because they're scared of the doctor or they're scared of a new person. And it's very difficult then to figure out whether it's just a child in a new environment or if it's the child who's really, really unwell and therefore is crying. So important to observe in the non-doctor setting. Important to observe their behavior and their gait as they enter the room. I think it's very, very important for us to introduce and welcome the child and the family who has accompanied the child into the room. You must ask for the child's name and try and refer to the child by his or her name. You must establish eye contact. A lot of children are comfortable in their parents' laps, and you must leave them in their parents' lap or in a situation that they're most comfortable in, because we must remember that the child is unwell and therefore brought to you, and they should be as comfortable as possible for as long as possible, because eventually you're going to examine the child and you're going to make that child cry. So best to keep them as happy as possible for as long as possible. You must ensure that the environment that you have around you is friendly. You must have toys available, preferably a bright, cheerful environment, some colors here and there, some toys maybe or rattles that make noise, just to keep the child engaged. And the most important thing in this slide, I would say, is for us to listen. Listen to what the parents have to say, families have to say. In some situations, listen to what the child has to say, because it will give you important clues. And on the right, you can see what we normally do as a part of the pediatric history. And this is something that those of you who are in pediatric clinics may be familiar with. We look at presenting symptoms like you would with an adult. You would look at a history of presenting illness and probably elaborate on the presenting symptoms that the child has come with. Pediatric history taking is a little bit more complex and takes a little bit more time, because we like to ask for a past history. We like to ask for a birth history. The child, was he born term? Was he born preterm? What was the birth weight? Were there any complications around the delivery? Was the child in the ICU for whatever reason? You'd like to ask for a development history. Now, if it is relevant to your presenting symptom, you will of course take a detailed development history. But if not, you'll just ask the mother whether she's concerned about the child's development in any way. You'll ask for a vaccination history again. If the history is relevant to something vaccination related, then a more detailed vaccination history. If not, you can ask the parent or the family to produce a vaccination card and sort of see what has been done so far. You'll ask for a family history. You'll also ask for an environment history, because a lot of illnesses are related to the kind of environment the child lives in. For example, if you have a child who presents with symptoms similar to asthma, you're going to ask whether there's any smoke exposure in the house. If there's any parent smoking indoors or outdoors, it becomes important for you to understand that. And the socioeconomic history, because it's important for us to understand how many people live in the house. Is there overcrowding? Is there ventilation or no ventilation? Those kind of questions, because it becomes important to sort of deduce your differential diagnosis. If I have to talk about a few examination skills that are important and relevant to pediatrics, I would say speak to the child directly. This is difficult, of course, in infants, but I think any child above the age of 1 will be engaged with you, maybe even younger than that, engaged with you when you speak to the child directly. You must examine the child where the child is most comfortable, and this is different in different age groups. An infant or a toddler would be comfortable in the mother's lap, whereas an adolescent may want to be the only person in the room when you're examining him or her, and therefore you must be aware of that and adapt as per the age of the child. Very important to plan the examination and explain it to the child. So you're going to tell the child what you're going to do. So I suppose I'm going to examine the child's chest. I'm going to tell the child that, look, I want to examine your ears, nose, throat, and chest. It's going to take 5 minutes. It's not going to be painful at all. If it's a slightly older child and you're planning to give an injection or a vaccine, then you must go ahead and explain that to the child before you do it. Plan your examination. By that I mean, suppose you want to examine the respiratory system and the cardiovascular system, and you're taking off the shirt of the child. Finish both at once. Don't try to do it in a sequential order. Do the respiratory system, go to the abdomen, palpate the legs for something, come back to the chest. The child is going to get irritable and going to cry and not be able to sit through the examination. It's important to plan what you want to do. Warm, clean hands. I cannot stress the importance of having warm, clean hands. The younger the child, the more important the temperature of your hands. Nobody likes a person touching you on your bare skin with really cold or wet hands. It's not nice. try and do a short mock examination. This sort of helps the child. For example, if I want to auscultate the child and the child is a little wary of what you're doing, auscultate the mom who's sitting, whose lap the child is sitting on, or take a teddy or take whatever soft toy you have in your room and just auscultate that so that the child knows that it's not going to hurt him or her. If you're undressing, please dress back. And at the end of it, don't forget to smile. It's so important. It makes such a big difference to all of our patients. And this on the right is what we normally do when we follow examination sort of, pro forma. We look at the general appearance of the child and make a comment because that gives us an idea of how sick the child is. Whether the child is happy and playing, whether the child is irritable, whether the child was examined while on the bed, the child was examined while sitting on the mother's lap, just how comfortable the child was when you were having a look at the child. General physical examination that, of course, we all know: pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Vital signs of the child: heart rate, respiratory rate, blood pressure, pulse oximetry. If you have a SpO2 probe, then that as well. Now, the additional important thing is anthropometry, and I'm going to come to that in a little bit because it's very important for pediatrics. We comment on the nutritional status of the child by taking a good height, weight measurement, measuring the head circumference if the child is less than 5 years old, plotting it on a growth chart to interpret it. We do a head-to-toe examination, which means that we look at the child and comment if there are any signs that sort of stand out to us. For example, if you're noticing that the child's hair color is different or has a white patch of hair or silvery hair, then you're going to comment on that. If you think something's wrong with the eyes, then you're going to comment on that. If there's something wrong with the tongue and the jaw, then you're going to comment on that. So just that, and then a systemic examination. And we all know that we have 4 systems that we usually examine: the respiratory system, the GI system, cardiovascular, and abdominal examination. And that is very similar to what we do for adults. Some comics that I just thought that I would share with you. So if you look at the one on the left, this is an adolescent who's sitting in a doctor's clinic. The doctor's asking the mom, when did Jimmy first walk? His name is not even Jimmy, his name is James. So obviously the patient is thinking, I'm James and he's so stupid. And the mothers come in with the complaint that James has got headaches. But the doctor's question is, when did he first walk? And mother's wondering, what has this got to do with headaches? So you need to ask relevant questions. You need to sort of address patients by the correct name. You need to adapt to the environment. And on the right, as you can see, this is a little child and a doctor's trying to auscultate the heart. The child is seated comfortably on the mother's lap. The child has a toy in his hand that he or she is playing with. The doctor has bent down all the way, is making eye contact with the child and auscultating the child in a position that the child is comfortable in and the child doesn't feel threatened at all. And so important for us to do that. I think this is a common sight in a pediatric outpatient department. So a little bit about growth. 4 important phases of growth that we talk about in pediatrics are, from the time of conception to birth. That is, the fetal growth is, of course, dependent on the uterine environment, dependent on genetics, dependent on stress levels in the mother, dependent on a lot of things. Following that, in the first year of life, and in this big picture, of course, 1.5 years of life, it's the infantile stage of growth. Now, this is the stage where most rapid growth occurs in terms of how big the children grow relative to their body size. It is when they need maximum amount of calories or nutrition as well. They also need a good environment in order to grow well. And of course, hormones play some role in growth of a child in the first year. Then you have childhood, which is probably between the ages of 2 and 12, which is where maximum growth occurs, usually determined by hormone levels, both growth hormone, thyroid hormone, a lot of other hormones as well, also determined by the environment, also determined by their genetic composition. You may have, I'm not sure if you know, that we look at something called a mid-parental height very, very often when we're evaluating children for short stature, which means we look at the mother's height and the father's height, and we sort of calculate what kind of average height you're expecting for the child. And then if the child is much below that, then you would sort of evaluate for short stature. So genetics plays an important role as well. And above the age of 12 years is pubertal growth, which again is hormone driven, but is probably determined by other hormones as well, which is testosterone and estrogen in addition to growth hormone. Now I've mentioned that the growth is influenced by genetics and environment. We monitor it at every well baby visit. We must formally plot growth on a growth chart, because only then will we understand if the child is following a pattern of growth or not. If the child sort of at the time of birth and in infancy is at the 50th or 75th centile and suddenly drops more than 2 centiles on the growth chart, then you're a little worried, because you're wondering if something has gone wrong with the nutrition of the child, let's say, and why that child has sort of dropped a couple of centiles in growth. So it's important only if you track the growth over a period of time, and that's what a growth chart does for us. And growth, of course, is affected by nutrition and sleep, very important for us to sort of inquire about that and pay attention to that in our outpatient visit as well. How do we measure growth? So for infants, we use this sort of a weighing scale, and we try and remove their clothes, try and remove the diaper as well, and put them on a weighing scale in order to measure their weight. For children who are a little older, they can stand without their shoes on a weighing scale. For height measurement, if it's an infant, we use something called an infantometer. Now, this has to be a 2-person job where you try and place an infant straight, try and straighten the legs, and use this one of these sort of vertical, I don't know what you call them, moves, and you can measure the length of the child. Whereas a slightly older child who can stand, so above the age of 1, you'd use a stadiometer. And it's important for us to understand that there are certain bony prominences that should touch the back when you're measuring height. The head should be straight, and then you would measure the height and plot it on a growth chart. Now, the other extra measurement that we do in pediatrics is measurement of the head circumference. This is done in children below the age of 5 years. This is done in order to understand if the head circumference, of course, is growing as expected. And if not, well, if the child has microcephaly or macrocephaly, which are both self-explanatory, or other problems like craniosynostosis, which means fusion of the head bones, or other kind of problems with the skull bone, you'll probably be able to pick it up only if you measure a head circumference. What we do is this method, which is a cross tape method. Basically, you place the tape on the supraorbital ridge and posteriorly on the occiput, and the largest circumference is what you measure and plot again on a growth chart. Now, on your right, you'll see the current growth charts that we're using for girls and boys. This is a combined growth chart of the WHO and the Indian Academy of Pediatrics. This has the height and the weight, does not have the head circumference. You'll need to use a separate chart for that, but we plot it over a period of time. Now, just to explain this growth chart in very, very basic terms, for those of you who have not seen it, on the x-axis, on the horizontal line, is the age in years. On the y-axis is the height in centimeter. The lines that you can, or the weight in kg, the lines that you can see here, the middle one is the 50th centile, the lowermost one is the 3rd centile, and the topmost one is the 97th centile. Anything lying in between 3rd and 97th is normal. Below that and above that is probably abnormal, and you'll need to evaluate. Similarly for height, same thing in both growth charts, but of course, this is gender-based and therefore they are different colors. Couple of slides on development of the child. And when we say development, we basically talk about all kinds of skills that these children acquire between the time of birth and between the age of and up to the age of 5 years. We usually speak about 4 major domains of development: gross motor development, fine motor development, language skills, and social skills. Now, gross motor development are large movements, things like sitting, walking, running, all of these. We have particular age cutoffs for when these children should be able to do all of these activities. We have some red flags, which means if a particular child is not able to perform a particular task by a particular age, then you'd be worried and keep an eye on it, or send the child to somebody who's an expert at assessing that. Fine motor skills are fine motor skills which you use your hands for. So when the child is reaching out for objects, when the child is grasping objects, what kind of grasp the child has, As they grow older, you'll understand that the grasp is finer and finer. So again, have age-related cutoffs for certain things. Language milestones and language developmental problems or speech problems are probably the commonest kind of developmental issues that we see in our clinics. And social milestones, which again, very important to assess, because things like autism, for example, will only be able to pick up if the child is not performing certain milestones. So we call, for example, a child who is 1 year old should be able to look at what you point at. So if I point at a fan and say fan, that child should be able to look at me, understand that I'm pointing to a fan and look at it. And if the child doesn't do that, then I'm a little bit worried and I'd keep an eye on that child. Lot of factors affect normal development. And as you can see this picture here, of course, the age, gender, and genes, but there's an immediate social environment, friends and relatives. What kind of family structure does the child have? Is it stable or unstable? What kind of parenting style is the child sort of exposed to? What kind of cultural attitudes does the family have? What kind of housing? What kind of socioeconomic status? All of this plays an important role in the development of the child. Then the local social fabric, which means in the just outside the house, in the surrounding environment, what kind of factors can play a role, like pollution, health service delivery. Does the child have access to basic health services? What kind of neighborhood is the child growing up in? Does the child have enough play facilities? Is there a good school that the child goes to? And then there's, of course, a lot of international factors and national factors, like how much is the country spending on vaccination, for example. Is the country a poor country or a rich country? Is it a developed country or a developing country? What kind of exposure does the child have in terms of media? What kind of natural disasters is the child sort of exposed to? What kind of rights are there for the child? Is somebody fighting for the rights of the child? So all of this play an important role in normal child development. Now, in addition to these 4 major domains, we look at cognitive development in areas in children that we're concerned with. We can also do a formal IQ assessment. Hearing and vision form a part of our developmental assessment as well. Hearing usually comes into place when we have concerns regarding speech, and one of the first few things that we assess. Now, important to look at this at every well child visit, because we need early intervention, or picking things up early and intervening early can really change the trajectory. And when I talk about trajectory, as you can see on the left side, this is just to understand that, for example, on the left, what you see right on top are gross motor. The second one is fine motor. Below that is hearing, speech, and language. And the lowermost one is social behavior. And we have limit ages, as you can see in the right side panel. And that is a red flag for us, as in if it reaches the limit age, the child is not able to perform a particular developmental milestone, then we're concerned and we refer the child to a developmental pediatrician. And as you can see on the right side, these are patterns of development. What you see in the x-axis is the age. On the y-axis is the developmental progress. Anything in the yellow is considered normal. Now, the red line is a child who is slow but steady, as in he's following developmental milestones, but he's probably doing it slower than his peers. What you see in the green line is a child who's probably developed slowly but steadily for the first 2 or 3 years and then sort of plateaued. And what you see at the lowermost line is a regression, which means the child has started losing some of the milestones that he or she had gained earlier. Now, these are the children that I'm worried about, the bottom 2. Whereas the one in the red, the slow but steady, I may decide to just wait and monitor. But of course, if there are any concerns, then you would refer to a developmental pediatrician. Everybody in this range would be normal. Moving on to immunization. So we know what immunization does. We know that there are vaccine hesitant communities, but we don't see that as often in India. And if we have access to free vaccines in the country, which we do, we have access to free vaccines from the government for all primary series of vaccination, then I don't see reason for parents to sort of not be able to vaccinate their children, but we still do see some vaccine preventable diseases in our ICUs even now. It is one of the most beneficial and cost-effective measures for disease prevention. Diseases like polio and smallpox have only been eradicated because of effective immunization policies. It's a public health policy, and therefore large-scale interventions are required in order to improve coverage of vaccinations. It contributes to active immunity. We have live attenuated vaccines and inactivated vaccines. And as we all know, basically what a vaccine is a small component of the antigen, whether it's a protein or a cell membrane is injected or given orally. And that gets absorbed by our body. Our body usually produces antibodies against it, and then we're protected for a long period of time because of the IgG antibodies, which tend to have memory and protect us if we ever are exposed to that antigen again. This is the National Immunization Schedule of 2023. Just to clarify, we have vaccines at birth 6 weeks, 10 weeks, 14 weeks. The pentavalent here contains 5 vaccines, as in vaccines against 5 diseases. And the new changes that have been made in the National Immunization Schedule is one provided by the government, is that they have introduced the injectable polio vaccine. Earlier, we were giving only the oral polio vaccine. Now we also have the injectable polio as part of the National Immunization Schedule. We also have Japanese encephalitis vaccine, which has been introduced, and that is only in areas where Japanese encephalitis is endemic. Some parts of Karnataka and North Karnataka is endemic to Japanese encephalitis. Otherwise, West Bengal and parts of West India, Japanese encephalitis is quite prevalent. Some of these vaccines earlier used to be optional vaccines like the rotavirus and the PCV. PCV stands for pneumococcal conjugate. These are now part of our National Immunization Schedule. And our National Immunization Schedule also has vaccines for pregnant women. Moving forward to the last bit of theoretical stuff before we go on to some more casual discussion. Nutrition, so important for optimal growth and development and for immunity. Why are children a sort of vulnerable group? Because children, especially infants, have low stores, have high demands because they growing rapidly. They need good nutrition for good neuronal development and good myelination, and they need good nutrition in order to overcome an acute illness, and they fall sick quite often. So they are very prone to malnutrition. When I say malnutrition, it may mean undernutrition or failure to thrive or severe acute malnutrition, or it may be obesity or overnutrition, which again is an emerging health problem. Our most important bit for nutrition is that we must emphasize on simple, sustainable, home-cooked meals. And this is, purely based on which area they come from, what kind of food is cooked at home, what is affordable, what is feasible, what is safe for those families. I'll start a little bit with breastfeeding or best feeding. A little bit cheesy, I know, but it's really true. We have the baby who is sort of suckling on the mother's breast. There are tactile receptors that are activated. The hypothalamus then sends impulses to the pituitary, and the anterior and posterior pituitary produce prolactin and oxytocin respectively, which help with the let-down reflex and milk production. We advise breastfeeding right from the time of birth, doing skin-to-skin contact at the time of birth, and breastfeeding the child within the hour of delivery helps with milk production, helps with mother-baby bonds. There's several advantages for the infant: lesser chances of infection, better nutrition, better cognitive development, better bonding, lesser diseases or inflammation in the long run. A lot of advantages for the mother. And as pediatricians, we always advocate that we must practice exclusive breastfeeding for at least the first 6 months of life. For slightly older children who have been started on complementary feeds and who are weaned, and for toddlers, this is a food plate. Half of the food plate, ideal food plate, should contain fruits and vegetables of different colors. And then of the remaining half, you should have some form of protein and some form of grains. And of course, on the side is dairy. And with all of this, the other thing that we'd like to sort of add into the nutrition bit is some form of physical activity. Now, not only are we focused on macronutrients, we're also focused on micronutrients, because vitamin deficiencies are very common in our pediatric population and can be easily treated. A word about obesity. Obesity is the new problem. I would call it the new pandemic, because we're just seeing so much of obesity, especially in the adolescent age group. Screen time is contributing to that. Healthy eating habits are are a few that are habits that pediatricians must sort of endorse, including eating as a family on the table, eating together, replacing food with healthier, replacing, store-bought food with healthier options, keeping screens off in parents and children off the dining table every time that there's a meal going on. So these are a few things that we sort of try and emphasize on when children come to the clinic. Lastly, adolescent care. And as you can see, this adolescent is into all of these social media apps. I was just trying to figure out what these are sometime back. And other than Facebook, Google, YouTube, and Instagram, I don't know any of the others. A little bit dated, I would say. But transition phases, therefore, needs special care. Lot of biological, psychological, social changes. Communicating with an adolescent, of course, is different. Very important, assent or consent from the adolescent before you start any kind of treatment, and maintaining confidentiality is very, very important in that age group. It's a beautiful balance between parental responsibility and authority and the child's developing autonomy. So adolescents form an important part of pediatric ethics as well. And I'll speak about that in a little bit. They also are exposed to a lot of high risk behavior, and therefore they become, that tender age group that we really have to take time out for. On the right, you can see HEADS, which is a mnemonic for the kind of history we ask in adolescents. And this history is asked both from parents and from the child themselves. What sort of home life is, and how, what are the relationships that you have with people at home? What are family dynamics like? What sort of education is happening? What's going on at school? Is everything okay? What kind of activities are you interested in? We ask the parent, are you worried about some sort of activity? What is the mood generally like? For D, we say, is there any exposure to drugs anywhere? What kind of diet is the child taking? And S can stand for a lot of things. Important to ask about sleep habits, because adolescent sleep habits are usually all over the place. Important to ask about sexuality, ask about sexual preferences, ask about exposures, because this tends to be, again, a big problem with adolescents. And suicide, because mental health problems, especially in that age group, are quite prevalent and important for us as pediatricians to address it. Now, putting it all together, and this is the end of the theoretical bits, and then after this, just a little bit about pediatrics before we sort of wrap it up. Be patient and empathetic. Tease out a good history, and 90% of your problem is solved. Be kind and gentle, but confident while examining. Observe keenly, very, very important. Clear communication is key. Only order tests that will give you answers. You must have an answer ready before you order tests. You should sort of expect what you're going to get out of the test before you order the test. Otherwise, you'll end up doing everything under the planet. And important for us to follow up carefully. Now, a little bit about why I chose pediatrics. When I was very young, I was influenced by outstanding mentors. Both my uncle and aunt were pediatricians. And I think as I grew up, I enjoyed watching what they did. And that was my biggest source of inspiration to choose pediatrics. Of course, as I got into medical school, I understood that medicine, pediatrics, and all of the medical fields are very logical, problem-solving sort of fields. And I enjoyed that. I was not inclined towards surgery at all. I may have had reasonably good communication skills. I felt that pediatrics had a lot of subspecialties that were emerging, and so there was plenty of scope in the future. Pediatrics is extremely gratifying, and you'll know that if you choose it. Children, as soon as they get well, they start smiling, they start running on the corridors, they start playing with you, and there's nothing in the world that feels as good as that. On the other hand, what you must know before you choose pediatrics, it's not easy to get into. It doesn't pay as much as the surgeons sort of get paid. They get paid really well. Long hours, emergencies in the beginning of your career when you choose pediatrics, medico-legal problems, yes, when you choose pediatrics. And it's a very tough job to reassure parents and tell them nothing is wrong with their child, because all patients who come into the clinic want some prescription when they go out, and to not treat or to reassure them that everything is fine is the hardest bit of pediatrics. What is different with children? I think amongst all of these things, this triadic relationship is the most important and most difficult thing to manage because the child can't tell you what the problem is. The parent interprets the problem for the child, and the physician has to interpret what is going on based on what the parent says and the child feels. So it becomes important. Obviously, as you can imagine, there are issues with communication as well. And you're treating the family, please remember. So I think that is the biggest difference between adults and children. You must keep the best interest of the child in mind at all times. You must not cause harm under any circumstance. And as I mentioned earlier, we see a large spectrum. For example, neonatology is a completely different branch. Adolescent care is a different branch. So we have a very wide spectrum, and we must refer to experts when we don't know what's going on. Just one slide on pediatric ethics because it's so close to my heart. These are a few ethical principles that we live by for pediatrics. Autonomy means having decision-making capacity. Beneficence means doing the best for the child or doing what is in the best interest of the child. Non-maleficence means doing no harm to the child. Now, all of these three promote individual health, whereas justice means making sure every child has equal opportunity in society. That is more for public health, but these principles form the core ethical principles in pediatrics. Now, this slide is a little bit crowded. These are all of the pediatric subspecialties. The ones that I've put on top are related to general pediatrics, genetics, emergency pediatrics, developmental pediatrics, adolescent medicine, infectious diseases, and probably pediatric intensive care as well. What you see in the second row and the third row are all different branches, just like the adult medicine has, pediatrics also has now. And it's interesting to know that if you do about 5 years of training in, let's say, neonatology, you can only treat preterm babies and babies who are term until they're 28 days old, and after that, everything else falls in the pediatric category. So you can imagine you're spending your life treating newborn babies, and you're the only person in all of the physician world who can treat babies who are that small. So it's really specialized and it's really, really beautiful. Few opportunities in pediatrics. We all know about post-graduation courses, MD and DNB. There are DCH courses as well, but I believe now all DCH seats in Karnataka have sort of got converted into MD seats. Please correct me if I'm wrong. There are, of course, super specialty courses that are emerging every year, fellowships and DMs. Few institutes offer DMs, and they're available in a few pediatric subspecialties, especially intensive care and neonatology related, but most of the specialties have fellowships. Fellowships are usually a year or two. DM is a 3-year course. Available India and abroad. It is the need of the hour in tier 1 cities. As you can imagine, every parent wants the best for their child. And if a general pediatrician tells the parent that, you know what, your child has asthma, which is something that a general pediatrician manages on a day-to-day basis, the parent is so worried that they keep asking to see a pediatric pulmonologist, and they come themselves to see a super specialist. So it is the need of the hour. However, super specialty courses can be expensive, and that's the only thing to keep in mind. Research in pediatrics is another whole different ball game. It is challenging, but very, very rewarding. The problem with research in pediatrics is that it is a little bit of an ethical issue. There are a lot of ethical issues in relation to research in pediatrics because children are such vulnerable populations. So therefore, it's a little bit challenging, but there are plenty of opportunities. And that is where I will stop. And I'm happy to answer questions on my personal experience, happy to sort of answer questions on general pediatrics or whatever you'd like. Thank you for giving me this opportunity.
Thank you, Dr. Neha. This was indeed a wonderful session, and I can see a couple of questions already there on the Q&A box. So can we take that before Dr. Aruna starts her communication session?
Sure. Yeah, that works. No problem.
Okay. So we have the first question from Abdul, which states, is thyroid genetically transmitted?
So yes and no. Yes, because if the mother is hypothyroid, then during pregnancy especially, then yes, we test the infant more rigorously than you would otherwise. Now testing a TSH level for all babies at birth has become a part of the newborn screening. So all children get universally tested. yes, it is genetic. It can, if your parents have problems with the thyroid hormone, it's likely that you have the same genetic abnormality and a problem with the thyroid hormone. So yes, the answer is yes, it is genetically transmitted.
Thank you, doctor. So the next question is from Ram Verma. If on weight by age chart, point comes below the 3ST and MUAC comes in normal range, then can we call the child malnourished?
So definition of severe acute malnutrition keeps changing. I know that the definition of severe acute malnutrition now is less than the third centile, or one of the other two criteria, one of which is the mid upper arm circumference. So yes, you can, if the mid upper arm circumference is below -3 standard deviation, you can, but please just cross check. There is a new WHO definition for severe acute malnutrition. And if it fits into that, then yes. But yes, you're right that if one of the parameters fit, then it does fulfill the criteria of severe acute malnutrition.
Thank you, doctor. So the next question states, what is the most common permanent disability in childhood?
Permanent disability in childhood. Now that's difficult to answer, but the most common developmental problem that we see in our outpatients in respect to developmental issues or delayed development are speech problems. And most of these speech problems or language problems are related to ear problems or hearing. So offhand, I would think that that's the most common permanent disability, but I'll have to look it up.
Okay. Thank you, doctor. So the next question is about breastfeeding. We have a couple of questions. What if powdered milk is given in the initial 6 months? Do breastfeeding have any health benefits on mother's health?
Absolutely. So for breastfeeding is the best feeding, there is no doubt. For a variety of reasons, many children go on to formula feed, or what you're calling powder feed, in the first 6 months. Now, this happens usually when mothers in the first week are too unwell to breastfeed or don't have enough breast milk, and the children are sort of losing more weight than what is expected. All babies, when they're born, within the first week lose about 10% of their body weight, but within 2 weeks are sort of gaining that body weight back and then start to increase. Now, if the weight loss is more severe than that, as in is more than 10% or falls too rapidly, then you're worried that the mother's not producing enough milk. And in some cases, we add formula milk. Formula milk comes with its pros and cons. Pros first, I would say, easier to prepare, keeps the baby full for longer, different types of formula are available, and can be administered by anybody other than the mother as well. Cons, I would say, breast milk is designed for the baby to be able to digest it really easily. Some children don't take to formula feed very well. And so therefore you have to be a little bit careful while introducing formula feeds. Second is the route of giving formula feed. If you're going to give it to a newborn baby or a very young infant through a palada or a spoon, that is safe. But if you're going to give it through a bottle, then bottle feeding has its own problems, most often related to contamination of the bottle. In very, very early stages, you have something called nipple confusion, where once the child starts feeding from the bottle, which is really easy to feed from, the child forgets how to suck from the mother's nipple. And therefore, breastfeeding becomes a challenge if you're trying to do both together. So there are issues with bottle feeding that can occur with formula given in a bottle. Overall, breast milk is designed in a way for the baby to be able to digest it. For example, I mean, this is a really interesting thing. When a baby is born preterm, the milk that the mother produces once the baby is able to consume breast milk is designed for a preterm infant. When the baby is in the first 2 weeks of life, the mother's milk that is produced of breast milk is designed for a 2-week-old to be able to digest it. And as the child grows older, breast milk contains the nutrients that the child requires. Now, this kind of fine tweaking is difficult to do with formula. So that answers your first question. The second question is what kind of benefits for the mother? Several benefits for the mother. Helps the uterus sort of contract after delivery. So important. So as to have a sort of contraceptive effect. Now, this is not 100%. Just breastfeeding doesn't act as a complete contraception for the mother, but it is believed that it helps with contraception. Breastfeeding helps with long-term problems like breast cancer because there's a reduced incidence of breast cancer in mothers who breastfeed. It helps with mother-baby bonding. There is nothing greater than breastfeeding for mother-baby bonding. It helps with weight loss for the mother postpartum. So yes, tons of benefits from breastfeeding, both for mother and baby.
Thank you, doctor. I think that was an elaborate answer on the entire breastfeeding process and the pros and cons. So we have the next question on sexual orientation of a child. Is it genetic or does it depend on the psychological environment the child grows in?
I think it's a mix of both, because it depends. I think you only understand it after puberty, because that's when you usually you understand your sexual orientation, you understand what kind of sexual preferences you have. Before that, those kind of hormones are not present in your body, and I think that you're not mentally mature enough to sort of give these things a label. So I think it's a mix of both. There is obviously some sort of genetic predisposition, but environmental factors influence decision making or influence label giving at that age. And so it's a mix of both. Yeah.
Thank you, doctor. So the next question is from Pradeep. What are the most common medico-legal problems, emergencies, or difficulties in pediatrics?
Oh, so that's a big spectrum. And I'll give you a few examples. If you have a really sick baby stuck on a ventilator and you've reached a stage where nothing is helping that child, you think and you and parents decide that you don't want to continue treatment because it's not going to help the child. But are you the right person to make that decision? Nobody knows that. That's a big pediatric ethical question. That's a big medical legal question as well. Second is drug doses, and we see this all the time. You will not believe it, but you get paracetamol drops, which are concentrated drops, which are meant for infants. You get paracetamol syrup, which is of a different strength, and that comes for slightly older children. And there's, of course, paracetamol tablets, which are for the adolescents. So if you mix up drops and syrup, and you sort of give a child paracetamol drops instead of giving them paracetamol syrup, you're increasing the dose of paracetamol n number of times. And if that causes side effects or toxicity, that becomes a medical legal issue. Like that, there are tons of things related to pediatrics that can become potential medical legal issues. And therefore, you have to be very, very careful with children while treating them, not take any risks at all, and always either ask somebody else or refer to a specialist when you have concerns. And follow up patients, of course.
Sorry. Thank you, doctor. So the next question from Swagat. As a pediatric pulmonologist, if you have a case of asthma, what are your advices to children in different age spectrums, as you said?
Okay. So very interesting question. All of the children who are referred to me for asthma need basic education. You must tell them that this is what is happening in your lungs. These are what is happening in your airways, and you need a test or a pulmonary function test in order to determine how severe your problem is. Then you need to explain to them that a lot of it is allergy driven, and therefore they need to avoid certain allergens in their environment. And this becomes important because in my practice, I note that this is lifestyle modification is the most important thing. This is what makes the difference. No smoking at all, no exposure to smoke of any kind. So smoke coming from agarbatti, smoke coming from mosquito coils, no exposure to any kind of smoke. Parents who smoke outdoors and then come in, you can still smell the smoke from their clothes. So no smoking at all in the environment. No exposure to house dust mite, because this is an allergen that most patients with asthma are sort of sensitized to, which means that their mattresses, their curtains need to be washed periodically and need to be house dust mite free. In addition to that, some children are sensitized to pollen, but not very often. Some children are sensitized to pets, and I'm asked this in every clinic with every patient, do I need to get rid of my pet? And the answer to that question is actually no. We can do an official formal skin test to understand whether or not you're sensitized, and only if you're sensitized and having severe symptoms, you need to get rid of the pet. Otherwise, we can either desensitize you, or it is not the pet causing the problem at all. In addition to this, we ask them to stay away from strong smells. So if your house has got recently painted, or if there is that mosquito, liquid in your house, any kind of strong smell tends to trigger off an asthma attack. Of course, exercise is really good. Stay away from all kinds of stressors. This is the usual kind of lifestyle advice that I would give in my clinic.
Thank you, doctor. So the next question is, how difficult or easy is it to ascertain the severe genetic defects in a newborn?
Tough question. We have a lot of antenatal testing nowadays, especially for things like Down syndrome. There's extensive testing based on your risk categorization. So big things like Downs, Edwards, Turner's, Patau syndrome will usually be picked up antenatally. There are smaller, and there's also an anomaly scan that happens antenatally, which can pick up major congenital malformations. The smaller things are picked up in the initial newborn examination. Neonatologists perform this examination. They are very good at picking up, if there's a murmur in the heart, then they will get an echo done. If there is a concern regarding hearing, they will do a more detailed hearing examination. If the thyroid level is off, they will start a thyroid medication and repeat the test. If there's something wrong with the hip, let's say, they will do a formal testing in order to evaluate it. So now, depending on where the child is delivered, you have extensive services in order to sort of pick up all these congenital anomalies. I think that in a place like Bangalore, most hospitals will be able to do most things. But in primary care settings, it depends on who's attending your delivery. If you have a pediatrician there, I think you're fine. If you don't have a pediatrician there and there is maybe just a doctor who's done MBBS or a doctor who's done Ayurveda or Unani medicine or homeopathy, then you might be in a little bit of trouble. That's sort of my comment on it.
Thank you, doctor. So the next question is COVID vaccine included under the immunization schedule? What age should be given to children?
Not yet in the national immunization schedule, approved for above the age of 12 world over, but in India, it's still optional.
Okay. Thank you, doctor. So if a mother suffers with psychological problems during gestation, is it going to affect the mental development of a baby?
Definitely, yes. The short answer to that is yes. Any levels of stress in the mother can affect the development of the baby in utero.
Thank you very much, doctor. Major diseases that affect children who are born to consanguineous married parents, I think, okay. And why that happens?
Okay, so major problems are genetic problems that can happen. Why does this happen? Because it's a little complicated for me to explain without a pedigree chart. I don't know if you know what a pedigree chart is. Basically, if you have autosomal recessive traits, now you may have heard the terms autosomal dominant and autosomal recessive. Autosomal dominant diseases are diseases that are there in every generation. So my grandfather has had it, my father has had it, and I'm going to have it. Autosomal recessive diseases are diseases that usually skip one generation and are present with every delivery. There is a 25% chance that you're going to have it. Now, let me say I have a beta thalassemia trait and I marry my first cousin who also has a beta thalassemia trait. Suppose the baby gets beta thalassemia, one abnormal gene from me and one abnormal gene from my cousin, then the child is going to have beta thalassemia as a disease. That is the basis of consanguinity, that in a family, everybody has probably one gene that's abnormal, which is manifesting or not manifesting. If it is not manifesting and two people with non-manifesting genes sort of get married to each other, then the likelihood of the child having the disease is much greater. This is, I mean, I hope that made sense. That's as simple as I can put it. What kind of diseases? All sorts of chromosomal anomalies. So Down syndrome, Turner syndrome, Edwards syndrome, Patau syndrome, all of these can be from consanguineous. All kinds of other autosomal recessive diseases. In my practice, for example, I see cystic fibrosis, all kind of muscular, neuromuscular genetic diseases like SMA, DMD. All of these can come from consanguineously married couples. So there's a whole wide spectrum, but I've given you a few examples.
Thank you, doctor. So the next question is from Varsha. It states, why seizures are common in children and how seizures go away when we keep some iron stuff? I think she means about those keys that we keep in the hands. Yeah.
Okay, that is a myth. Keeping a key or an iron thing on the hand does not do anything at all. So if you are aware of anybody doing that practice, please sort of discourage them from doing it. It doesn't do anything. That is an age-old practice that has just passed on from generation to generation and does nothing. Why are seizures common? Probably again genetically driven. There is no real cause for it. What do we do to treat them? We give them anti-epileptic medication after we do a series of tests, including an EEG, to determine the cause of seizures. I think that much of an answer will be okay at the moment.
Thank you, Doctor. So we have a couple of questions which states the common criteria as in convincing parents, especially from the social economic status, underprivileged status, to take test which is compulsory for children, or maybe even scheduled vaccinations which are mandatory. How do we really convince them on this?
Very interesting question. See, what needs to be done is that you need to tell them. I think what makes the difference is giving them access to a primary health center that is friendly. Okay, that makes the biggest difference, because all primary health centers should be providing these vaccines for free, or all government hospitals in the city provide these vaccines for free. Now, you need to be able to convince them that what vaccine they're getting for free, and it's providing the child lifelong immunity against certain deadly diseases. If you put this in as simple terms as possible, and nowadays what we do is we also use the example of COVID, because everybody knows COVID. Everybody knows that taking a vaccine against COVID will keep you out of the hospital at least. And therefore, they are more willing to use vaccines than they were earlier. So if you use this example, even with the lower socioeconomic strata, they will understand the importance of vaccination and decide to get their kids vaccinated. Important to send them to a primary health center. So that much convincing if you can do, then everything else will be taken care of by the doctor in the primary health center. Nothing, I mean, it's a common scenario, but solutions are quite simple.
Thank you, Doctor. So the next question is how to deal with emotional trauma of seeing parents and infants in pain. I mean, basically all the emotional stuff they go through. I
think that comes with the profession. No, it's maybe a little bit harder in pediatrics than it is with adults, because even with adults, when you see somebody suffering, then you obviously feel for them. But as a doctor, you have to sort of there's a difference between sympathy and empathy. Sympathizing is feeling bad for somebody else, but empathizing is understanding what they're going through, but still standing sort of out of the situation. That's what we need to develop, and I think it's a skill that comes over a period of time. Even today, if I have to enter the pediatric oncology ward, then it takes me 2 days to sort of get into that mental sort of space, to be able to deal with children who are facing death and dying almost on a daily basis. But if I'm working in that ward every day, then I sort of get accustomed to it, and I don't think of it like that anymore. Instead, I have a more positive frame of mind. I tell myself that, look, this child is facing death and dying. I'm trying to do something to help that child, and then that motivates you to go into work every day. So it's a frame of mind, and it comes over a period of time.
Thank you, Doctor. I think we're already we passed time, and it's 4:08. So can we take a couple of questions, or is it fine? Should we just close it? Maybe I will ask the scholars to mail us the queries, and we'll pass it on to you whenever you have time.
Yes. Sure. That's fine. I've shared my email address. I can put it in the chat box again. So if you have questions, or if you want to know any details, then you can please mail me, and I'll get back as soon as I can.
Yes. So thank you, Dr. Neha. And now I would like to invite Dr. Aruna Jagadish to enlighten students on a few communication skills. And this talk will be only for 10 minutes, scholars. So please wait and make use of this opportunity. Hello, Dr. Aruna. Good evening. Very glad to meet you.
Hi. Can you hear me now?
Yes, we can. Yes, we can.
Yeah, I am using Neha's laptop to talk to all of you. So good afternoon, all of you wonderful young students who are attending today's session. And I think Neha has done a wonderful job in introducing pediatrics to all of you. And I hope you really enjoyed and learned a little bit of the importance of this particular field. Now, as we had discussed earlier with Sudha and Jenny, we were thinking that we should introduce some sort of soft skills every session. And when you look at pediatrics, the one thing that I felt which was most important was empathy, which Neha did make a mention of towards the end of her talk. So as you all know, empathy is being in one's shoes of feeling what the other person feels. And I think pediatrics is one field where empathy plays a major role. Now, let me just give you two examples rather than trying to talk theory. Let's take an example of parents bringing in a small 3-month baby who has been crying the whole night. The child has been up and screaming his or her lungs out, and the young couple, new parents, are not able to figure out what's going on, and they just try to carry the baby, try to console the baby. The mother feeds the child, but nothing consoles the child. They call up an ER and they're told what to do. They do some basic stuff like giving some clearing the nose, giving some paracetamol drops, stuff like that, giving some colic drops, and the child does settle down. However, the parents are anxious and they come to your clinic in the morning or the hospital, wherever you are, to figure out what had gone wrong. Now, let's look at two sets of doctors who are going to be interviewing or taking care of this child. Now, Dr. A interviews the parents, says, okay, what happened? And they say, yeah, my kid has been crying at night, and though he's better now, and the doctor examines the child and says, you know what, everything is fine on examination. I wouldn't worry, must have been some colic. Don't think too much about it. Don't overanalyze it. If it happens again, you can always come back to me. Gives a small prescription and sends the child. Now, do you think that these parents who have been up the whole night with a baby who was screaming his or her lungs out would be satisfied with this type of an, response? On the other hand, you have Dr. B, who calls the parents in and say, would you like to tell me what happened? Would you like to describe what happened at night? And then the parents talk about how the child was crying in any position. He was uncomfortable. And even after breastfeeding, he was crying. Even after giving him paracetamol, he took a long while to settle down. And, things like that. And now he's better, but we wanted to know what happened. Now, Dr. B consoles the parents. I can understand your baby has gone through a very rough night. And I also realize that you guys must have been up the whole night and you must be really tired. Let me examine your kid. And on examination or after examination, tells them that, everything seems fine. I've examined your child. I'm not finding anything abnormal, but maybe I would like to review again. And what you have done seems fine. And maybe if the child wakes up even tonight and cries, you do the same, but come in tomorrow morning and then let me review and maybe do a few tests and see what's going on. Now, when the approach of the doctor is like this, empathizing with the parent, understanding what the parents felt about their baby. They're very sad when their children cry so much. Understanding that the parents themselves are exhausted and tired. When a doctor gives a few extra minutes, talks to the parent, understands from where they are coming, this is going to give them confidence that their child's problem will be solved. And this is being empathetic, and this goes a long way in pediatric practice. Knowing your subject, being good in the skill of examining, giving vaccines, all these are extremely important. Being updated, knowing what's the latest. Like Neha told us, the latest in vaccination, that is the 2023 schedule, she told. Every year the schedule changes and she's given us the latest schedule. So reading and being updated, all this is important. You have an edge over many other people when you're also empathetic. Now let's take another scenario. Let's take a mother bringing in her 14-year-old son, Karthik. He's brought to the clinic wheezing very badly. He's like, you can hear the wheeze in your consulting room even when he's outside in the waiting room. Now, what you do as a doctor, you first tell your front office staff, kindly check his vitals and just give him some nebulization. Let's bring the child, let's settle him down before we do anything else. The boy is given some nebulization with some oxygen, and he feels better after about 15-20 minutes. And that's when he comes in for a consultation. Now, as they come in, usually what we see in our scenarios, in our clinics, is that parents hardly give an opportunity to their children, even if they are adolescents, to talk. They keep telling us everything about the kid. And this mother starts off, Karthik has been a wheezer since he's young, and he was very good, or he was doing well as long as he took his medication well, his inhalers well. But now he refuses to take. And we keep having wars at home, but he doesn't listen to me. He's been sick whole night. I've been up whole night. I missed my meeting. And I don't know how to deal with my son anymore. And she blurts out all this to the doctor. Now we have Dr. A again, who looks at Karthik, examines him, and says, "You are better now because I've nebulized you with the required medication. You know you're an asthmatic. You know you need to take your medications. You better do it. Otherwise, you're going to keep coming back to me and I'm going to keep nebulizing you. So now you take charge of your health and your illness." And he sends them off with a prescription. Karthik is obviously not very happy. He's not even spoken a word during the whole consultation. Let's see how Dr. B will manage this. Dr. B calls them in and he looks at Karthik and asks him, "How are you feeling, Karthik, now?" And Karthik says, "I'm better. Did the nebulization help you?" He says, "Yes, doc, I can breathe now." We gave you the Astelline and the Budecort, which you normally take with your inhalers, the same medication, and I'm happy you're feeling better. Then he says, "Karthik, your mom has been complaining you're not taking your inhalers. Do you want to tell me why? Do you have any reasons? Are you bored because you've been taking it for so many years? Do you feel that your inhalers are not helping you? Have you been reading and you're worried that I'm giving you a steroid through an inhaler? Or are your friends teasing you in school, Karthik, because you're taking an inhaler before you start a run or before you get into the pool?" Now, when Dr. B will ask open-ended questions to him, Karthik has to communicate. He will start talking to the doctor and will give him his reasons. This type of an interaction where you interact with the boy who's a 14-year-old, you empathize with him, saying that you understand that at his age it may be a little difficult to do these things for various reasons. But you also tell him that, remember, you have asthma and that you need to take these medicines. Let's work out how it will be easier for you. Shall I make it a 1-day, a 1-day treatment, rather than twice a day? Like, let me see if I can change your inhalers where you need to take it once in the morning before you go. And you give the boy the responsibility to make these decisions. He is probably going to work on it and he'll do better. This is showing empathy to your teenager. It is not just talking to the parent. So when you try to understand, put yourself in the other person's shoes, as we say, you will be able to help patients much, much better. And over here, in a young child, it is the parent who needs the empathy. In older kids, especially teenagers, it is the child himself. So take this extra few minutes and let the patient know that you actually care for them, you actually feel for them, and then your treatment will have an added advantage. And I think I just wanted to add these two examples about empathy for today's talk. Okay, thank you, students. Jenny, you want to take over?
Yes, doctor. Thank you very much. First of all, thanks to Dr. Neha for this wonderful talk on general pediatrics. It was a pure delight listening to you on the different aspects of pediatrics, the subspecialties it covers, the opportunities it has, and what is it to be a pediatrics, maintaining the little nuances needed and assuring parents about their child. It was a very detailed session, right from the infant care to adolescent management, and most of all, maintain peace in the family when the kid is not well. Thanks to Dr. Neha for this, and special thanks to Dr. Aruna for having this talk on empathy. I'm sure students got a great insight on how to deal with patients while being empathetic. I'm sure this is a great takeaway for our scholars. Thanks to both the doctors, and thanks to all the participants who have joined in today on a Sunday evening. I'm sure today many of you have made the decision of becoming a pediatrician, choosing that specialization. So with this awareness, I would like to bid adieu and have a good evening, all of you.